So this is the next topic: common fractures, etiology and their treatment. Fractures of distal radius and ulna. So this, you see, this is the wrist joint. Now here you see, this is thumb, this is little finger, and here will be the distal radius and ulna. Fractures at this level. Fractures at the level of distal radius and ulna. This is my hand, you can see distal radius and ulna. Now we are studying this fracture. Etiology usually fall on outstretched hand. Fush, F-O-O-S-H, fall on outstretched hand. Very common, 1 to 6 in all fractures. Bimodal incidence is common in childhood, 6 to 10 years, as well as in adults. This is bimodal. Scaphoid and ligament wrist injuries may be present. Classification systems are based on AO system and Frankman system. Histological eponyms named Coley-Smiths are still used. To avoid confusion, stick to the describing fracture by anatomical method. For example, dorsally displaced fracture of the radius and shortening and ulnar deviation. So what is there? Dorsal displacement. So in this manner, if you see from the lateral side, this is the lateral side, this is radius. If anywhere fracture is there, and it is dorsally displaced, and you see what is the radial deviation, what is there? The dorsal displaced fracture, distal radius is shortening and ulnar deviation. Dorsally displaced fracture of distal radius. So now this one is radius, and it has displaced, if you see from the lateral side, this is displaced dorsally and ulnar deviation. And ulnar deviation means deviation to this side. Ulnar deviation, you have to fix it then. Important radiological feature is to access is, so in children, fracture usually involves epiphysis region, and these fractures are classified as Salter-Harris system. So for children, important radiological features to access. The parameters give an idea of severity of injury and the stability of the fracture. Dorsal cortex commutation, intra-articular extension, radiocarpal distal radioulnar joint. So articular extension, radiocarpal or distal radioulnar joint dislocation. Ulnar styloid such as TFS injury. Loss of radial inclination, normally 22 degree. Loss of palmar tilt or dorsal angulation, normally palmar tilt. Loss of radial height from the distal ulnar. So if you see, this is the, and this is radial tip, this is ulnar tip. So if it goes up, loss of palmar tilt or loss of radial height, 11 millimeter from distal ulnar tip to radial styloid. So this is radial styloid, this is ulnar tip. This, if height is lost. Now what is the treatment in children? The treatment of the distal radius usually treated by closed reduction. In children, closed reduction, manipulation, application of well-modulated plaster. If very unstable in theater, radioulnar complex fracture, or if fracture has slip position in the plaster for manipulation, then internal fixation with percutaneous K wires are required. So this is the question is coming. Colis fracture, when there is comminuted fracture and person is very heavily working, you need open fracture reduction or K wiring. Now treatment in adults. Fracture with dorsal displacement and angulation. Undisplaced stable molded elbow plaster immobilization for 6 weeks. There is no displacement, is stable, then just put a molded plaster below elbow behind the plaster and we keep it for 6 weeks. If the fracture is displaced and it is stable, then close reduction, no need to open it, and plaster immobilization. If it is displaced as well as unstable, close reduction, percutaneous K wire. If it is complex intra-articular fracture or highly unstable fracture and can be treated with anatomic pre-contour radial locking. Fractures with a volar displacement. Smith's fracture. So Colles is dorsal displacement. This is the radius. Suppose there is a fracture at this end. This is dorsal displacement and this is volar displacement. Volar is the palmar or this side. Volar displacement, fracture of the radius, you called it as Smith's fracture. Are treated by volar buttress plate. So you have to put a plate from the volar, support the fracture like a shelf, propping up or supporting the distal fragment. Intra-articular fractures, if it is intra-articular, if it has gone into the joint space. So this, from here there is joint space, it has entered into the joint space, then it is called as Barton, volar Barton. Internal fixation is mandatory as it is highly unstable fracture, ulnar styloid. So this has got into the interarticular, so internal fixation is mandatory. It is highly unstable fracture. Ulnar styloid fractures do not often require fixation unless fragment is large. It may present TFCC injury. Commonly, Smith's fracture is also again outstretched hand on the direct blow. High energy impact involved, therefore look closely for neurovascular status or as displaced angulated fracture affect proximal Monteggia and distal Galeazzi radioulnar joints. It is so Galeazzi is this distal and Monteggia is at the upper end. This is the elbow joint, you get upper end is Monteggia. Fractures types, usually transverse fractures of radius and ulna, may be angulated, cortical green stick fracture, plastic deformities. Fracture types, adults usually have transverse and oblique fractures of the radius and ulna. Isolated ulnar fracture, this is called as, this one is the hand, here is ulna, here is radius. A person is trying to prevent the stick injury from this ulnar border, so that is called as nightstick fracture. Nightstick fracture, so it is a fracture of the ulna. Green stick is for the children. Here is the nightstick fracture, named after the mechanism of defending the direct blow by the policeman's nightstick or trachyon. Displacement and significant angulation are indication for fixation. Remember, the forearm is a force parallelogram and fracture of only one bone will usually result in dislocation of the other bone at proximal or distal. These fracture dislocations are Monteggia, proximal ulnar fracture with dislocation of proximal joint, and Galeazzi is distal radial fracture with dislocation of distal radial joint. So what is green stick fracture? Close reduction and cast immobilization from wrist to elbow in line traction, a key to initial reduction, and often all these require to realign. Use minimal force if periosteal hinge is broken during the reduction, and fracture may displace completely and become unstable. Plastic deformity need to be corrected. Displaced fractures are often unstable and can be treated by ORIF and plates and screws. Fracture dislocation like Monteggia and Galeazzi, close manipulation, cast simulation. Usually important to achieve. Treatment in adults is to achieve close reduction for the adult. Shaft fractures, undisplaced fractures managed by above elbow cast. Displaced fracture needs open reduction and compressed. Nightstick fracture of the ulna is splinted by the radius so that undisplaced, if the fracture is displaced more than 50% displacement, then open reduction is important. What are the complications? Malunion, non-union, close-up follow-up of the fractures, manipulated fractures, and X-ray at 1 to 2 weeks is mandatory to watch for slip position. Malunion can present with functional problems. Non-union usually treated by open reduction and debridement of the non-union side. It is not usually necessary to remove the metal work from the radius unless cause significant problem. Dislocation near the elbow joints. Second commonest injury in children is 8% of the children fractures. Usually this is a fallouts and result leads to less than 9 years supracondylar fractures of the humerus, more than 9 year dislocation of the elbow, then shoulder injuries. Salter Harris is used for this supracondylar fracture based on the mechanism of injury, extension type and flexion type classified into Gartland system. Type 1 there is undisplacement, type 2 is angulated displaced, both posterior cortex is intact Type 2 posterior coronary index, and there is angulation or displacement acting as a hinge. Now 3 is complete displacement, 4 is completely displaced and unstable. Supracondylar fractures. Access neurovascular status and document beforehand, reduce under general anesthesia and traction. Up to 5 minutes may be required. The manipulation to correct rotation, valgus, varus, tilt, and finally so for extension deformity, try to flex the displaced type fracture. Fracture should be reduced and stabilized. Yes. So any immediate vascular component, however, pulseless and cord, hand, or pulse that is lost post reduction in pin. True loss of the radial pulse may be due to vascular spasm. Sometimes radial pulse supracondylar fraction typified a good capillary refilling after detraction, but slow return of the pulse. Failure of pulse return may be due to injuries and require vascular surgical opinion. Partial is treated by direct repair. Complete dissection or disruption may direct repair may contracture. Untreated vascular injury will result in fibrosis and contracture of the foramen that is called as Volkmann's ischemic contraction. This is devastating and debilitating condition and should be avoiding an explosion of vascular damage. Neurovascular neuropraxia is common. Gradual recovery may involve radial nerve. So radial nerve, anterior interosseous branch of median nerve. This commonly injured nerves, median nerve, radial nerve. Malunion. Incorrectly reduced fractures will not remold and can lead to decubitus valgus and gunstock deformity. Much less commonly KY common following cast management of the type 2 remolds poorly. Lateral condylar fractures according to Milch, depending on how much of intra-articular surface is involved. Type 1 fracture through the growth center of the capitulum, Salter-Harris type 4, and type 2 fracture medial to growth center and can involve trochlea, Salter-Harris type 3. Displaced fracture, or if with or either two cannulated screws KYS, the fragment is always considerably larger than expected X-ray due to condyle not being fully ossified. It is not reduced and fixed, the fragments will disappear. This is due to pull of the wrist jaw extensor arising from the lateral epicondyle. This will lead to cubitus valgus deformity and can present in the later life and ulnar nerve palsy. As it has been chronically stretched, ulnar nerve palsy is there. Tardy means delayed. Medial condylar fractures noted to be confused with epicondylar fractures. These fractures occur in similar pattern to lateral epicondylar fractures. Treatment is usually for condylar fractures. Epicondylar, medial epicondylar fracture avulsion, high chances of elbow dislocation, and then remain caused. Essentially same as medial radial head fractures. Usually these are caused by dislocation of the fracture. Montage fracture, fractures near the neck. Radial head neck fractures, treatment angulation, sling is properly immobilized. 30 to 60% reduction may be attempted and being an debate. 60% more than 60% reduction under G is required. Olecranon fractures can be difficult to spot. Proximal, the undisplaced fracture may require cast extension.